Bismillah ar-Rahman ar-Rahim. Our subject in fetal echocardiology, we talk about fetal heart rate arrhythmias. Fetal arrhythmias, it's an important subject. Heart rate, this increases progressively over subsequent 2 to 3 weeks, becoming 110 beat per minute by 5 to 6 weeks, 170 beat per minute by 9 to 10 weeks. This followed by a decrease becoming on average 150 by 14 weeks, 140 by 20 weeks, 130 by 10. This is heart rate. Although the healthy fetus, the heart rate is usually irregular. A beat-to-beat variation of approximately 5 to 15 beats per minute can be allowed. A slow fetal heart rate is termed fetal bradycardia. This is usually defined as a heart rate below 100 beats per minute before 6.3 week gestation, or heart rate below 120 beats per minute at 6.3 to 7 weeks. A rapid fetal heart rate termed fetal tachycardia. This is usually defined as a heart rate above 160 to 180 beats per minute. A rate of 170 beats per minute may be classified as a borderline fetal tachycardia. A rapid and irregular fetal heart rate is usually termed arrhythmia. Fetal bradycardia refers to an abnormally low fetal heart rate. This is regarded as a sustained first trimester heart rate below 100 beats per minute. Underlying conduction abnormality following chordocentesis. Vagal cardiovascular reflex, especially if transient during second trimester, this may occur from fetal head compression, umbilical cord occlusion and compression, maternal exertion, possibly from inadequate maternal gas exchange, hypoxia caused by myocardial depression, stimulation of stretch receptors in aortic arch and all carotid sinus wall. This may be transient vagal cardiovascular reflex leading to fetal bradycardia, not a result problem in the heart, outside the heart. Okay, this condition as we talk. Fetal bradycardia classification: fetal sinus bradycardia, fetal brachyarrhythmia, fetal bradyarrhythmia, fetal partial AV block, fetal complete AV block. Commonest type of bradyarrhythmia is blocked premature atrial contraction. Association is increased risk of chromosomal anomalies, especially trisomy 18, maternal connective tissue disease, particularly with bradyarrhythmias. Differential diagnosis is general consideration include transient sinus bradycardia from excessive pressure. Fetal tachyarrhythmia. The normal fetal heart rate ranges are approximately 120 to 160 beats per minute at 13 weeks and 110 to 150 beats per minute at term. Frequency up to 170 beats per minute considered mildly abnormal, whereas overt tachycardia is usually defined as a heart rate exceeding 170 beats per minute or 180 beats per fetal tachyarrhythmia. Premature atrial contraction, the commonest form of fetal bradycardia, fetal bradyarrhythmia. What we mean by premature atrial contraction, PAC. Premature atrial contraction is caused by an early electrical impulse coming from somewhat in the atria outside sinus node, from area in the atrium, from area and tissue in the atrium, outside the sinus node, which control normal heart rate and sequence and rhythm. BAC is a premature contraction coming from a piece of tissue in the atria, not transmitted to the ventricle, outside side of premature atrial contractions. As again, this is BAC, in mode of premature atrial contraction, not transmitted to the ventricles. As we see, this regular, and this is premature atrial contraction. Premature atrial contraction, cardiac dysarrhythmias, premature atrial contraction. This is atrial contraction, it's normal rhythm. This is BEC, premature atrial contraction. These synchronizations piece of atria give impulse outside the sinus, premature atrial contraction. Mode Doppler image show BEC, again BEC with subsequent early ventricular atrial contraction. As we see, cardiac rhythm, normal and abnormal vetus, premature atrial contraction, isolated blocked upper panel, conducted lower panel, premature atrial contraction. As we see, this is atrium, this is premature atrial contraction. This is aorta and this is superior vena cava. Also this aorta, this is a pulse mode, P pulse, not continuous wave, not M mode. This aorta, this superior vena cava, this atrium impulse, this premature atrial contractions. Upper panel conducted and lower panel other blocked form. Lower panel contracted form, upper panel. This is various types of premature atrial contraction. Complete EV block. As we see, in complete EV block, atria beat at their aneurysm. The atrium beating at their aneurysm, and none of their impulse transmitted to the ventricles. The ventricle has a slow rate, 40 to 70 beats per minute. This is how many atrial contraction? More and more. How many ventricular contraction? Less than atrial contraction. So complete EV block, sinus node which give atrial impulse not transmitted, completely plugged to the ventricle. This is one cause of bradyarrhythmias, one cause of bradycardia, complete EV block. Other type of fetal M mode of tracing complete EV block, demonstrating atrial wall motion during out phase of with a small slower ventricular contraction. Multiple atrial contraction, as we saw, slow atrial ventricular contraction not follow atrial contraction. So this is atrium impulse controlled by sinus node, not transmitted to the ventricle, complete EV block. Each one chambers have its own rate. This is one cause of bradyarrhythmias. Okay, fetal supraventricular tachycardia, atria and ventricle are contracted rapidly with 1.1 EV relationship. Irregularity of supraventricular tachycardia should be due to transient interruption and reinitiation, or could reflect transient alteration in the EV conduction during ongoing atrial tachycardia. Distinction could prove important when establishing medical therapy. This is fetal supraventricular tachycardia as of dysarrhythmia of the heart. Atrial flutter, atrial rate ranging from 250 to 150 up to 500 beats per minute with a fixed or variable EV block flutter. Again, another type of dysrhythmia. M mode echo of the EF, atrial flutter. Flutter contraction of the atrium indicated by a small arrow, as we see. Multiple atrial contraction. EV conduction 2 to 1 every 2. Atrial contraction conducted 1 to the ventricle, and the ventricular contraction indicated by large arrow. This is atrial flutter. Atrium so rapid at 250 up to 500 contraction. Not all transmitted to the ventricle, but percentage 2 here, 1 here. This is a type of dysarrhythmias. And this is multiple atrial contraction, atrial flutter. This is ventricular contraction, not follow atrial contraction. This is 2 contraction, 1 contraction in the ventricle. This is type of atrial flutter. Tachyarrhythmia. Okay, احنا on the heartbeat more than 170, more than 180. This is tachyarrhythmias. Okay, increase the supraventricular tachycardia, defined as 1 by 1 EV conduction in which atrial contraction precedes ventricular contraction. Heart rate in supraventricular tachycardia most commonly range from 200 to 300 beats per minute. Is either paroxysmal or instant in nature, associated with fetal hydrops in 36 to 64%. Supraventricular tachycardia. In mode of SVT with a short VA interval. First white line placed on the peak excursion of the left atrium wall, and second placed on the peak extrusion of the right ventricular wall. Third line on the consecutive beat atrial contraction, EV interval markedly longer than the EVA interval. EV interval much longer than VA interval, as we see in this 3-1 type of SVT. Any mode of supraventricular tachycardia with a long VA interval. Supraventricular tachycardia with a long VA. Supraventricular tachycardia, 20 weeks of pregnancy, transverse scan through the fetal thorax, showing four chamber view of the heart and precardial effusion, as we see this fluid between precardium and the heart, precardial effusion, as this is hypoechoic. This is in supraventricular tachycardia of the, and again same details, so more increasing four chamber view. Okay, 22 weeks of pregnancy image 3 shows mode examination of the heart with an fetal heart rate 231 beat per minute. Image 4 shows scan of the fetal abdomen with ascites. Here ascites, above we see pre-effusion, here we see ascites, fluid in pericardium and in peritoneum, free fluid. Tachycardia. Supraventricular tachycardia, 20 weeks of pregnancy, reverse flow at the level of the ductus venosus was present during fetal tachycardia. All this is precardial effusion, ascites, reverse flow in ductus venosus. All this is manifestation. What you mean? You have intrauterine growth restriction. There is stress in fetus. Ductus venosus, reverse flow. Mode Doppler shows supraventricular tachycardia. Atrial heart rate as fast as well as ventricular heart rate. This is both are fast, atrial heart rate and the supraventricular tachycardia. Cardiac function, fetus heart ultrasound Doppler diastolic dysfunction in cardiomyopathy. Prolonged isovolumetric relaxation time. Increased myocardial performance index, MPI. This is cases of